I'm a family physician. I work in Toronto, and I'm also the CPD program director at the Department of Family and Community Medicine in Toronto. I'm thrilled that we can continue to bring you these sessions in collaboration with the Ontario College of Family Physicians. And I'm going to turn things over to our OCFP president, Dr. Jobin Varughese, to introduce the session. Jobin.
Thanks so much. And so as we are here to speak about the different winter season viruses and also the menopause, I wanted to take the quick opportunity to remind everybody that this is a 1 credit per hour group learning, which you can get up to 32 credits, but that there is some issues with the main pro currently, but as you can see, we have some ways to do that. So we do ask you to keep your eyes on that so we can start doing that after December 16th. Next slide. I want to do a quick land acknowledgement that we acknowledge the lands on which we are hosting this meeting and include the traditional territories of many nations. This OCFP and the DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and the DFCM respect the Indigenous people have rich and cultural traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Eleanor, back to you.
Great, thanks, Jobin. And I'm calling in from Toronto, the lands traditionally used by the Wendat, the Anishinaabe, the Haudenosaunee, the Chippewa, and the Mississaugas of the Credit. And I wanted to reflect today on some wisdom and guidance that I received on the topic of priorities earlier this year from Dr. Chase McMurran. Dr. McMurran is a family physician. He identifies as Indigenous, and among other roles, he is the Indigenous Health Education Lead at our department. You may remember Chase as he was a panelist on our September Community of Practice, and he was speaking about managing patient expectations, an issue which I feel for many of us does at times impact on our joy at work. However, what you may not remember is that as moderator of that session, I left Chase with just a few minutes to deliver his speech or his presentation, as I was striving to make sure that we answered all the questions on the topics of the day. At our debrief, Chase gently observed how we had placed the part about looking after ourselves right at the end of the session, where, as so often happens, it got a little squeezed for time. So now I recognize we're all logged on today to learn more so that we can care for our patients better, but I am going to make sure that I leave time at the end of today's session for a special presentation by Dr. Varughese. Further to that, I would encourage you, as we enter this very busy month of December, to not only do the amazing work that you do of serving your patients, but to also remember that you too have needs and to not always put them last on your to-do list. Next slide, please. Okay, so today's session is put together by an amazing scientific planning committee that's so much work behind the scenes. Next slide, please. We have 2 panelists today, as well as Dr. Dan Wacharski in the background for Q&A. And I'm going to ask each of them to introduce themselves. So Dr. Janine McCready.
Sorry, I'm Janine McCready. I'm one of the infectious disease doctors at Garron in Toronto, and I have no conflicts.
Thanks, Janine. And Dr. Sue Goldstein.
Hi, Susan Goldstein. I'm a family physician here in Toronto as well. I have received a number of honoraria for speaking and the like. I am going to address any bias, any products that I do talk about, particularly off-label, I will identify as such. And these are my conflicts on the slide here. Thanks.
Thanks, Sue. And over to you, Dr. Varughese.
Yeah, thanks. As you can see on the slide, I'm the OCFP president and get honorary for that and stipend. I'm also the interim assistant dean of primary care education at TMU School of Medicine and the associate vice president of academics at William Moseley.
Thanks, Jobin. And maybe Dan, I'll just get you to introduce yourself as well. Thank you.
Sure. Hi, everybody. Daniel Wachowski. I'm one of the associate chief medical officers of health. I'll be quietly answering questions in the chat today.
Thanks so much. And I've already introduced myself. I get an honoraria from the OCFP as well as for some work that I do for McMaster, neither of which I think pose a conflict of interest for today. Next slide, please. So just a reminder on how to participate in case you're new to these sessions. So please post your questions in the Q&A If you see a question that you're interested in, remember to upvote it so I can prioritize those when I ask the questions of the speakers. And then use the chat for networking purposes to share resources, comments, and all the like. Next slide, please. So for today, we're going to get started with Dr. McCready, then we'll break for questions, and then we'll hear from Dr. Goldstein, and then break for more questions, and then hear from Dr. Varughese. We'll finish up everything before 9 a.m. in terms of the main content, but if we have a lot of questions, then we'll come back to questions between 9 and 9:15 if we need to. All right, I'll turn things over to you, Dr. McCready.
Perfect, thank you. So just to kind of get us started, set the stage, this is where we are at so far in our viral respiratory season. So we've seen steady levels of COVID-19, and then the brown bar here is for enterovirus rhinovirus, so just lots of minor coughs and colds. RSV is starting to take off, and these numbers here mirrored in what we're seeing in the emergency department in hospitals. So younger kids, especially under 2 and under 1, coming in with RSV infections and requiring admission. And then flu really hasn't gotten started yet. Next slide. So this is just to give us an idea of where we are compared to last year. So COVID seems to be, not really falling into much of a seasonal pattern, and we're still seeing kind of scattered cases, and we do see probably a few admissions each week, normally not due to COVID, but people that have multiple comorbidities and have potentially COPD, underlying lung disease, congestive heart failure. So it doesn't take much to kind of tip them over and cause them to have an exacerbation, or again, older people with falls after they have a virus. Influenza has not really started yet. We last 2 years saw a much earlier rise in influenza, so really push the flu shots to get things. There's still time to get protection. We kind of expect that we will see rising levels over the next few weeks, and then a peak towards the end of December, early January, and then RSV again starting to increase. Next slide. So to turn the tables a little bit, to talk a little bit about mycoplasma, this has been in the news a little bit more, and I'm sure all of you have been seeing more cases of this, and we have seen more cases of young people, in addition, actually admitted to hospital with this, more than I'd ever seen probably in my career so far. So these are recent data from Public Health Ontario, just put out last week, kind of showing the % positivity for mycoplasma PCR by year. And you can really see that here in 2024, there was a significant increase on previous years. Obviously, these are pandemic years, but even on pre-pandemic years. So an average of an 18% positivity rate across all age groups here in Ontario. Next slide. And this is just to give you a sense of how that 18% breakdown breaks out over the year. So it was low over the winter months, and then started to increase in the summer, June about 7%, then up to July 14, then really doubled and stayed high August, September, October. Started to come down a bit in November. This is up until November 15th, but still high. And I think we should start to see further decreases, as normally mycoplasma is late summer and early fall, and as winter and cold and flu season comes, usually mycoplasma drops. So I would expect to see a drop in this over the coming months. The caveat to this too is that these are PCR tests, so they do not tell you anything clinically about the patient and whether they are still actively infected. So if someone had mycoplasma a month ago, their PCR testing could still be positive now. And so that's when you guys are thinking about ordering tests or treatment, usually your clinical judgment is paramount in this, because if the patient's already improved and they previously had symptoms compatible with mycoplasma and improved, then this might not be, the positive test might not be relevant. Next slide. So COVID, influenza, mycoplasma, oh my. So kind of what do you do from a practical perspective now that we have this extra infection in the mix this year that can present more with viral symptoms? So I think the most important thing to remember is that most patients with a mild mycoplasma pneumonia infection will recover without antibiotics. So we do not need to start, the first line treatment for mycoplasma would be azithro or clarithromycin, but you do not need to be starting out on everyone that comes to the door that you're worried might have mycoplasma, because most people will get better on their own. So the people that you should initially think about testing or treatment for these people are generally people that you would be worried about in any context. So those are immunocompromised, they have underlying lung disease, they have sickle cell disease, if they have extrapulmonary presentation, so they've got hemolytic anemia, encephalitis, arthritis, really bad mucocutaneous disease with rashes and ulcerations. And really those people that you think are going to have severe illness or complications. And they may benefit from also Tamiflu, Paxlovid, or antibiotics. So people that you'd be worried about in any context. Next slide. And so if they don't fit into those categories, other reasons that you should think about mycoplasma would be that, so someone comes to your office, they have a presentation and you're worried they have community-acquired pneumonia. So they have fever, they look quite unwell. You would normally do a chest x-ray on them. So you still do your chest x-ray, it shows an infiltrate. Still would be recommended to start them on the typical treatment for community-acquired pneumonia. So generally start them on amoxicillin. If then after 72 hours, they're still not improving on appropriate treatment, so still have fever, still feeling unwell, if it's just an isolated cough, which is stable, that's not an indication to change treatment. But if they're otherwise worsening, then that's a time to think about mycoplasma. If you didn't treat them, but they're, haven't gotten better, so for most viral things, they should start to improve. But if they're worsening after the first 72 hours, they have a persistent fever for more than 5 to 7 days, other persistent symptoms, and then other high suspicions for mycoplasma. So not improving, and they have some of these other features listed on the slide, then those people you could think about testing or treatment. Next slide. And sorry, one thing there is that you may, depending on where your area is and if you have access to testing, if you have a high suspicion, you may just want to go ahead and treat them. But as I said, in the coming weeks, we should say less mycoplasma, so it should be less of an issue. And I just wanted to say one word about pertussis, because I kept mentioning their persistent cough. So there have actually also been increasing numbers of pertussis here in Ontario in the past year. So you can see this again, Public Health Ontario data up until the end of October, showing for 2024, we had 1,329 cases of pertussis, which is much higher than any previous year. The most recent year with any similar number of cases was way back to 2012. So again, keep it in your head, not a super common thing, but something we are seeing more, and a low threshold to test in infants, especially under 4 months. If the coughing is lasting, more than 2 weeks and there's no other clear cause, they have that characteristic inspiratory whoop and paroxysmal coughing, or they're coughing so much they're vomiting, then to think about it. And you may see atypical presentations in especially in adults or adolescents who have been vaccinated. So we've had cases admitted to hospital actually with post-tussive syncope, and that ends up being pertussis. Next slide. Okay, you can't do one of these talks without mentioning COVID-19 vaccines. And I've been doing these for a few years now, so maybe at one point we have to talk every time about vaccines, but the current mRNA vaccines target the SARS-CoV-2 strain KP2, which is an Omicron subset. And as of early November, the most common strains here in Ontario were KP 3.1.1, which is an Omicron strain, and then XEC, which is a recombinant strain, and then MC1 was just starting. So it's not a perfect match, but it will still reduce severe disease, and it's a better match than the vaccines from a year ago, which were for XBB, which is not around anymore. So it's still expected to get some protection. So the NACI recommendations for this year were that for COVID vaccine is recommended, and their language is very specific. So recommended for all adults over 65, and then those that are at higher risk. So if you're a resident of LTC or congregate setting, underlying medical conditions at risk for severe disease. So, any immunocompromised, lung disease, heart disease, there's a whole list of things, but anyone that you think could have a higher risk, pregnant individuals, and then individuals from First Nations, Métis, Inuit communities, or racialized or equity deserving communities, and then those who provide essential community service, so frontline workers like all of us. All other individuals greater than 6 months of age may receive that vaccine. So it's not necessarily recommended, but likely some benefit. And the main thing is if you haven't had COVID that you know of in the last 6 months to a year, then more likely to benefit. So if you haven't haven't had it, then it's still reasonable to give anyone over 6 months that vaccine. Next slide. So I think this is my last slide. So just a quick word on masking in clinics. So many hospitals have moved to masking in all clinical settings since November 1st. I don't think necessarily you need to do that in clinic, but it's really risk assessment. And so thinking about your patient population, thinking about your personal risk, and deciding, what best you want to do. If you, leading into Christmas, you have a big gathering plan and you don't want to get sick, I may throw on my mask for those days just to make sure. And it really depends on, who you're seeing. And I find, before we had mandatory masking here, a lot of my colleagues were wearing their masks at the beginning of all the encounters when they were seeing patients. And then when they made sure they weren't having symptoms and they knew themselves they weren't having symptoms, then they would, take off the mask, because it's a two-way thing to protect you, but also to protect the patient. So I think, really using your sense. And then I think the other thing is too, if you have people at home in your household that have symptoms and you're still going to work and you want to protect your the patients, then reasonable to mask in that setting too, so you're not inadvertently passing anything on at the height of the cold and flu season. And next slide, I think that's it. And I just, just got to give kudos to COVID for all those people who didn't think it was going. So this one's dedicated to all the people that didn't believe in me when I was just getting started. We're still talking about it however many years later. And I think that's it.
Great. Thanks so much, Janine, for bringing us up to date on where things are at and giving us lots to think about in terms of what's coming our way or down the pipeline. I thought actually we'll start with just a couple of questions around COVID. Specifically, is there any new evidence or what's the latest on the cumulative effects of repeated COVID infections? Yeah, great question. I mean, I think we are still learning this, and there's lots of kind of research being done. There's some data that's showing that with repeated infections, there may be increased risk of, long COVID, other unusual kind of complications, which we see with any infection. So anytime you're exposed again and you have another infection, there are going to be those small risks. And with COVID, because on a population level, we had millions of infections all at the same time, we do see these, not all that rare, but fairly rare complications. So on balance, that's why it's generally recommended to get vaccinated still, because your risk from a vaccine and any side effects from that are far lower than any of the rare but still possible complications that you're going to get from COVID. So we don't have firm data, but we are still seeing, unfortunately, cases of long COVID, even with people developing after their, second, third episode of COVID. So it's mild in most people, but obviously not in everyone. Thanks, Janine. And also around COVID, in terms of COVID vaccine, a question from Hal: what's happening towards making better COVID vaccines aimed at something more durable than the ever-changing spike protein? Yeah, I mean, great question. There's certainly ongoing research, and I think they're trying to look at that to see if there are other targets, and as well, potentially a combined flu, COVID, plus or minus RSV vaccine to make it even easier for delivery if we're thinking about this on an annual basis. Great, thanks, Janine. And now I'm going to turn things over. There's quite a few questions around mycoplasma and pneumonias generally, since we are definitely seeing a lot more of them in the office than usual. First question is around the high rates of mycoplasma, which you spoke to, especially in those aged 5 to 17. And in this question, the person had written 16.3% of a subset of 135 specimens had mutations that suggest resistance to macrolide antibiotics. So what antibiotic regimen, exact days and duration would you suggest in adults? Yeah, so PHO just recently came out with that data. The recommendation is still to use a macrolide as first line. And I think that, again, the first thing to remember is most people will improve without antibiotics. So, not everybody needs antibiotics. If it's a mild case and they're already improving, you do not need to treat with antibiotics. But if you do, then azithromycin 500 and then 250 to complete 5 days. If you don't know it's mycoplasma, but you think it's still an atypical infection, in hospital, we often do azithromycin 500 daily for 5 days or
if it's still sick at that point, then 7, but 500 and then 250 times 4. And then or clarithromycin and BID for, I think it's 7 days. To be honest, I never use clarithromycin, but clarithromycin is just as good for mycoplasma.
Okay, and then I guess thinking about treatment still, can you speak to treatment recommendations for pneumonia in kids? Is it still reasonable to start with amoxil 90 milligrams per kilogram per day divided TID, or should we be starting something else given higher rates of mycoplasma?
Yeah, great question. So Sick Kids is actually working on a document right now, and I've been in touch with them to make sure that, you know, all the recommendations are on site. And so their recommendation is still, again, you know, not one of those high risk kids, not someone admitted to the pediatric ICU, but the first line would still be amoxicillin. And then again, if they're not responding after 72 hours or they're or worsening after 72 hours, then that's when you would consider the atypical coverage. So they have still recommended, again, amoxicillin first line, and then consider the addition of the macrolide. And, you know, importantly, we expect these numbers should decrease over the next several weeks with the cold weather. And then with treatment, I just wanted to say, you know, one other thing, if they aren't responding to the macrolide, then the next line would be doxycycline for adults, not for children. Fluoroquinolones like levofloxacin, moxifloxacin can be used, but I would really avoid those if you don't have to, because much higher risk for C. difficile, especially in adults, much higher risk for all kinds of side effects, and also rising risks of resistance. And if there is any possibility of tuberculosis, then the fluoroquinolone can sterilize the cultures and also lead to resistance in it. So don't use fluoroquinolones unless you really had to. That's more my stewardship hat, but just want to put in a plug for that. Okay.
Okay, great. That's helpful to know. And I think actually you might have answered one of the other questions, which was around if somebody had a reaction to Zithro or Clarithro, what would your next option be? And I think you just said it's doxy.
Yeah, so doxycycline 100 milligrams POBID for 7 days would be your next option.
Okay. A question just generally, is there an understanding of why the rates of mycoplasma are so high this season?
Yeah, great question. So, I mean, we do see traditionally kind of cycles and epidemics of mycoplasma about every 3 to 7 years. And again, we don't know for sure. My guess is that, you know, we probably had our last cycle a few years before COVID, and then everyone masked, nobody got it for 3 years, like everything else we've seen during COVID. And now we have this huge, because as you said, the highest numbers are in the kids 10 to 19, which is usually when they are. So then you have this cohort that's never seen it at all. And you don't have sustained immunity to it necessarily, but those kids probably have no immunity to it. So again, susceptible population, rising numbers, and yeah, I think that's probably part of it. Yes, but certainly much higher than we've ever seen in the last, at least in the last 10 to 15 years.
Okay, well, that's helpful to have a better understanding. Just around the diagnosis, if we are suspecting mycoplasma, should we just order a chest X-ray or do PCR? Also, what about the nasal swab? What are your recommendations around making the diagnosis?
Yeah, so I would start with a chest X-ray, and then if your symptoms are, you know, you're more suspecting a mycoplasma, so they aren't very like super sick, you're not worried about, you know, Streptococcus pneumoniae, reasonable to do the swab. The public health turnaround, that's the only issue, is it may be on the slow side. So the best is a throat swab. Nasopharyngeal swab would be fine as well, so kind of second best, but preferred would be a throat swab sent to public health. Sick Kids runs them, I think, twice weekly, but that would only be through the Sick Kids emergency department. And so if the child is stable or the adult is stable and they're not, you know, unwell, you can do the swabs and then wait for those to come back. And then if they're positive, treat. And if they're better by the time you get the swabs back, then you don't need to necessarily initiate treatment. If the person is, you know, quite unwell and you're worried about them, then either you can just treat empirically, or you can do the swab, treat at the same time. And then if you happen to get the swab back before before they're done the treatment, then you could always stop the antibiotics.
Okay, great. Another question just around chest X-rays. Jenny's written here, I've typically not ordered follow-up chest X-rays in otherwise healthy kids and teens, but now many imaging reports are recommending repeat imaging. Can you comment on this?
Yeah, that's a good question. So I routinely don't see, follow-ups for kids and adolescents. So I mean, in adults, we would routinely do it because, you just want to make sure there's no underlying lesion. I would suspect the risk would be pretty low when kids have that. But I would defer to probably you guys because you see more, or, our pediatric experts on that.
Yeah, no worries. So another question just around pneumonia on chest x-rays, or just generally, this attendee wrote in that she had a 9-month-old baby that had bronchopneumonia on chest x-ray in August 2024, but no consolidation. They treated with antibiotics, but now wondering, was it viral pneumonia? And how do we differentiate between viral and bacterial pneumonia so that we can use antibiotics judiciously?
Yeah, so that's super challenging. It's not easy, and especially when you have a sick person or kid in front of you. I think, access to viral swabbing is the most helpful thing, but I don't know how much access you guys have to being able to do like a multiplex viral swab and send it into public health. I know in our emergency department, it's extremely helpful because we will call back all of the children that are positive for RSV, influenza, and COVID. And the majority of them have actually been started on antibiotics. And then once we have a RSV swab that's positive, we're able to stop. So the things that I find helpful from a clinical perspective when you're reviewing the cases is kind of duration of symptoms is quite helpful. So if kids are still sick after, more than 72 hours and have a fever for more than 5 to 7 days, that's more likely to be bacterial. Not always, and we have certainly seen prolonged fevers with viral illness, but those are some things that make me think more likely to be bacterial. Or if they've had an illness improve and then they get a recurrent fever, that makes me more worried about kind of a superimposed bacterial infection. Again, can be very challenging because I find especially this year, there's so much around that the kids are getting sick like every week. And it's like, is this which one ended and which one began? So it's hard to tease out sometimes, but clinically, those are, two things that are helpful. And then the distribution on chest x-ray can be helpful. So if it's a frank lobar pneumonia, more likely to be a typical bacterial pathogen like a pneumococcus. It could still be mycoplasma. But again, if they're improving, then you might not need antibiotics anyways. And if it's more of a diffuse, not a focal localized consolidation, then that's more likely to be viral. Viral doesn't tend to give you a one specific area of a lobar consolidation.
All right, well, that's helpful. And it's also always reassuring to hear that infectious disease is also having a hard time distinguishing between bacterial and viral. Last question on pneumonia. Just to review, what adult antibiotic regimen do you use for the average patient community-acquired pneumonia? Z-Pak or other?
Yeah, so for outpatients, if they don't have risk factors for high disease, amoxicillin actually still would be your go-to. I wouldn't recommend a Z-Pak or azithromycin as first line for typical, your first presentation of pneumonia that you don't think is mycoplasma. Because the rates of resistance are high. They're probably 20 to 40% for a macrolide against a typical pneumonia like streptococcus pneumonia. So for someone that presents initially and you want to give them their first line, it would be amoxicillin. Or if they're a higher risk individual with comorbidities, diabetes, you're more worried, then amoxicillin clavulanic acid, 875/125 POVID would be your other option. And then if you're worried about atypicals, they're not improving, you're more worried about mycoplasma, that's when you would add on either azithromycin or clarithromycin. But really amoxicillin is still your first line because the resistance rates for azithro for typical are too high to trust it.
Okay, and when you do add something on, there was a question around this, do you continue the amoxil and add the macrolide?
Yeah, good question. So if you're not sure, if typical or not typical, then like you don't have a mycoplasma swab, or maybe they've had a little bit of improvement, but they're still quite unwell, then you can continue the amoxicillin to complete 5 days and add the azithro. If you get a mycoplasma swab back that's positive, or they have someone in their family that has mycoplasma, or they really have had no response to amox and they don't have a clear lobar infiltrate, then you could stop the amoxicillin and change to the macrolide.
Okay, great. Now I'm going to give you one more question just before we turn over to Sue, just around pertussis. So how quickly after symptoms develop do we need to treat pertussis in order for antibiotics to be effective? And do antibiotics work if they're started more than 2 weeks after symptoms?
Yeah, great question. So, and every time I get a pertussis question, I have to look this up. So I mean, obviously the earlier you treat, the more it's going to help. It doesn't, if you get the diagnosis later, it's still helpful to decrease the kind of burden of infection and the spread to people around them. So still recommended to treat if it's later. But the likelihood that it's going to significantly decrease the duration of illness is low at that point. So it often gets missed, and we often don't find it till later. And then it would be a question of monitoring their contacts and theoretically thinking about prophylaxis for them, depending on risk factors. So yes, I kind of having a high suspicion for it, and then at least stop the spread of it around the person is important.
Great, thanks, Janine. We're going to stop Q&A for now for you. We'll come back to you if we have time at the end of the session. Thanks very much for answering the many questions. And I'm going to turn things over now to Dr. Goldstein.
Thanks. Good morning. So thank you for having me back. We're going to do a quick review and talk about some of the guidelines that inform the prescribing and talk about what's new. Next slide, please. So the review, for those of you that weren't here in the spring, www.mq6.ca is my website. It's supported by Canadian Menopause Society. It is now bilingual, and you will find a total number of assets in there to basically start to finish know how to address the menopausal patient. So if you don't want to listen for the next 10-15 minutes, you can go to sleep and read this later. You'll find the MQ6 assessment tool, the algorithm for treatment, and the online interactive decision tool, which is based on the algorithm logic, but we'll figure it out for you, give you some treatment recommendations, take you to the treatment tables. And today, as we talk about the guidelines, it will help you understand the logic that's in the algorithm and what supports it. Next slide. And just a quick, have a look at the FAQ section on the website, because I often get the same questions, and I see I have a number of them today again. You may not remember what I say today. These are some of the questions I always get asked, and they're the small prescribing points and little finesse points. Next slide. All right, so let's talk about the guidelines. We're going to talk about menopausal hormone therapy, which is MHT. You all know the indications are vasomotor symptoms, POI, which is premature ovarian insufficiency, early menopause, hypogonadism, prevention of bone loss and osteoporosis. But if that's your only reason to treat, use bone drugs. Similarly, indication treatment of GSM, genitourinary syndrome of menopause. But if that's your only indication, then we use the products specifically that are locally acting for GSM. Next slide. MHT is the most effective option to manage moderate to severe vasomotor symptoms. It can be safely initiated and appropriately screen women without contraindications who are either less than 60 years of age or less than 10 years from their last period. There's no fixed duration of use. Median duration of vasomotor symptoms is about 7.5 years, but it depends. If you don't have flashes until you've stopped getting your periods, so you're postmenopausal, then those flashes on average only go about 3.5 years. But if the flashes start while women are still getting their periods early in the menopausal transition, you can have 12 years or more of flashes. And that's important to think about when you are prescribing and you're counseling patients about how long they need to be on meds. You can continue into the 60s, past 65, if there are persistent bothersome symptoms. But remember, with age, women are at increased risk of stroke and clot, so you want to reduce the dose to the lowest effective dose and switch to transdermal. Next slide. So what are starting doses? We say low to standard dosing of estrogen, but remember in the POI or early menopause patients, you may need to start higher. In fact, you do need to start higher, usually almost double or more of these doses. So standard dose would be like 0.625 of conjugated equine estrogen, 1 milligram of oral estradiol, a 50 microgram transdermal patch. And when you discontinue, it doesn't matter. You can stop cold turkey or you can taper. I prefer to taper because sometimes you can't get people off altogether. And this way you can establish lowest effective dose. Remember, in menopausal women, less than the age of 45, so early ones, you need to treat these women to the average age of menopause unless they have a contraindication because you want to prevent long-term health consequences. So hormone therapy is preventive in this younger group. There is efficacy to prevent cardiovascular disease, mortality, dementia, and osteoporosis, which our early and premature menopause patients are at risk for. Here's the bad news. In most naturally menopausal patients, hormone therapy does not prevent dementia. Sorry, we wish it did. The data just doesn't support it. There may be a small subset of ApoE4 carriers for whom it might, but for the general population, it does not. And in fact, started after 65, particularly with CEE, does increase risk of dementia. Also, in our naturally menopausal patients, it does not improve cognition. And I know everyone has a lot of questions about this, but there's just not data to support that it does. Next slide. So individualized care, consider risk assessment, patient preferences, offer non-hormonal options for women with contraindications or who prefer not to take MHT, and address the breast and cardiovascular risks. Next slide. So breast cancer risk. We now have 20-year follow-up data from the WHI, and this is what we know in that 20-year data. For the people on estrogen alone in that study, which was CEE, there was a decreased risk in breast cancer incidence and breast cancer deaths, and that persisted through the follow-up data even after the study and the intervention stopped. Similarly, for the E plus P arm of the WHI, there was an attributable risk, and that's the one we should talk about, which is rare, less than 1 per 1,000 women per year, increase in breast cancer incidence. Say that, don't say 30% increase. It's too scary and it's misleading. That rare increase was in incidence of breast cancer, but there was no increase in breast cancer mortality. And that's important. More cases, but not more deaths. And when you're counseling patients, important point to use. Next slide. So cardiovascular risk, there's a lovely 2015 Cochrane review and looked at all the studies at the time, pooled all the data together, real great analysis. And this is what they concluded. In the studies where there were what we call the young healthy women, so less than 60, less than 10 years after final menstrual period, average baseline cardiovascular risk. When they were given MHT, we saw an increase in VTE, which is about 2 times normal. We know the clot risk is worse in the first year, but no increased risk in stroke, no increased risk in cardiac disease. And in fact, there was a decrease in heart events and a cardiac and all-cause mortality. So there's cardioprotection in that group based on that meta-analysis. But in the older patients and the higher risk ones, so patients who had been started after 60, after 10 years after final menstrual period, or who had elevated baseline cardiovascular risk, they saw an increase in VTEs as well, higher. They saw increased risk of stroke, and there was no benefit for cardiovascular disease. So the conclusions from this were that when they looked at overall mortality, all-cause and cardiovascular mortality were not elevated in the whole cohort, and that was reassuring for cardiovascular safety for MHT. And as I said above, earlier initiation has the greatest benefit for cardiovascular health. However, MHT is not recommended for primary or secondary cardiovascular protection. Important point. Next slide. This is what we all ask about. Perimenopausal treatment. You have to consider who you're treating. Remember, MHT is not a contraceptive. So perimenopausal patients, you can treat them. That's people still cycling or the first year of amenorrhea. You have 4 options. The first 2 will not provide contraception. Not every perimenopausal woman needs it. So you can give E plus P, estrogen plus progesterone, a cyclic regimen, daily estrogen Progestogen, 12 to 14 days of the month, you will get a withdrawal bleed. And you want that because if you try continuous, the women will get a lot of breakthrough bleeding and stop. You can use progestogen alone. You're seeing a lot of this. It is less effective for vasomotor symptoms compared to estrogen. It does have some sleep benefits. And if you're going to use it for VMS, you have to go to higher doses, up to 300 milligrams of progesterone or 20 of MPA. Third option, off-label, estrogen plus 11-ogestrel IUS 52 microgram, 52 microgram, which is a Mirena. So there's a 5-year study that shows safety and efficacy for vasomotor symptoms for that combination. And of course, low-dose combined hormonal contraceptives. For postmenopausal women, you can use E plus P. We suggest a continuous cycle. Most patients do not want to get a breakthrough bleed or a period. You may, on a continuous cycle, which is daily estrogen and daily progestogen, get some breakthrough bleeding up to 6 months. That can be normal. After that, you do need to investigate. You also have newer regimens that don't require the addition of progestogen. I'll speak to in a minute, the STEER and the TSEC. And remember, for your hysterectomized patients, estrogen alone is fine. There was a question about what if they've had endometrial ablation, and those, again, doesn't apply to hysterectomized patients, but if you have a patient with endometrial ablation, you do need to use a progestogen. Next slide. So why do we care about the addition of a progestogen? So side effects, not a lot of women don't tolerate it. Bloating, fluid retention, breast tenderness, mood changes. So there are 2 newer products. First, the TSEC, that's conjugated equine estrogen 0.45 plus beta-doxyphene, which is a SERM, 20 milligrams, all in 1 tablet per day, oral. This estrogen plus SERM combo is Duoviv. The SERM acts as an antagonist to protect the endometrial lining. In the studies, what's interesting and unique here is that they saw no increased risk of breast density. So people ask, well, when should I really think about this per se? So if you have a patient who has a positive family history, or a lot of breast cancer anxiety, or they have baseline elevated breast density, or breast pain, that's one reason you may think to go to this product. The STEER, Tibolone, 2.5 milligrams a day, that's Tibella. That is a synthetic sex steroid, which has estrogenic and weakly progestogenic effects. It also has androgenic effects. So it has been used in Europe for years for libido, but that is not a Health Canada approved indication here in Canada. It also has better breast profile. So as you can see below, both of these products, they avoid the progestogen side effects. You have less breast pain compared to typical E plus P. You have better amenorrhea rates compared to E plus P. So faster, they're both oral continuous regimens, so faster to amenorrhea, less breakthrough bleeding. They both have bone and GSM benefits, as does E plus P. And the data to date shows cardiovascular safety. Next slide. So on the website, you can find fulsome tables. I get a lot of questions about the doses and what's available in Canada. And if you just go to mq6.ca, you'll see tables like this with the names and the drug names. Next slide, please. I said I'd talk about what's new. So there is a new product. We talk about bioidentical, which sort of bioidentical. People say bioidentical, they really mean compounded meds. But bioidentical is what the body makes, which is estradiol and progesterone. So we now have a new product, which is 1 milligram of estradiol and 100 milligrams of progesterone in a tablet, 1 daily continuous regimen. That's by Jiva. Next slide. What about the non-hormonal options? So remember, in Canada, until recently, almost all the non-hormonal options are off-label. So you can use SSRI, SNRIs. You can use gabapentin. We used to be able to use pregabalin. 2023 guidelines says no more pregabalin. There's too many side effects. It's not that effective. So no longer. Gabapentin, yes. Pregabalin, no. You can use oxybutynin. And then there's clonidine, which is on label, the only one of these that's on label. Clonidine is not as effective as the others. It can cause hypotension. So the 2023 American guidelines from the Menopause Society also said remove clonidine. It's still on my deck and on the website for now because it was the only thing we had on label. But it will be coming off, and I'll tell you why in 10 seconds. So non-medical CBT, hypnosis, weight loss, all has evidence and indicated for non-hormonal options, as is stellate ganglion block, which is a small surgical procedure. And what is new in the medication for non-hormonal are we now have a new class of drugs indicated for VMS. It's the NKB receptor antagonist. Next slide, please. Little bit of physiology. Can we get to the next slide, please? There we go. All right. So candy neurons, KNDY, kisspeptin, neurokinin B dynorphin. These are in the hypothalamus. These neurons send those three neurotransmitters, particularly the neurokinin B, down to the thermoregulatory center, which are neurons in the median preoptic nucleus of the hypothalamus. So neurokinin B gets signaled down to our temperature center, stimulates that sends a signal to the periphery to vasodilate, open the blood vessels up, sweat it off, bring temperature down. Candy neurons are under the control of estrogen, as well as neurokinin B, and estrogen has a negative feedback loop. So in normal days, there is estrogen circulating, and it sends negative feedback to suppress the activity of the candy neuron, and everything stays in balance. Next slide, please. Thank you. So what happens in menopause, your estrogen levels drop. You lose the negative feedback of estrogen, and the candy neurons go wild. They swell up. They start pouring out neurokinin B, that neurotransmitter. They send lots of signaling down to the thermoregulatory center. Those neurons have neurokinin receptors, NKB receptors. You stimulate those neurons, that over-signals the periphery. You get lots of signaling, sweat, sweat, sweat. And now we understand that's what a hot flash is. So how does a neurokinin B receptor antagonist work? Well, it blocks many of the receptors, in particular the NK3 receptors in the thermoregulatory center, so that in the absence of estrogen, when things try and go wild, it suppresses that and blocks the effect of this extra neurokinin B that's being secreted, so we don't get so many hot flashes. Next slide. So these are on label, indicated to reduce frequency and severity of moderate to severe vasomotor symptoms in postmenopausal women. There's evidence for reduced sleep disruption and improvements in quality of life. We have two. Fezolinetant, which is Vizoa, is an NK3 receptor antagonist. It is now approved in Canada as of this week. So we now have something on label, non-hormonal. 45 milligrams a day. Contraindications are cirrhosis, severe renal impairment, use with strong and moderate CYP1A2 inhibitors. Side effects are headache, elevated liver function tests, abdominal pain, diarrhea, insomnia, and nausea. With the elevated LFTs, the data to date shows that either with time spontaneously that will resolve or with discontinuation of the medication. But because of that, you require monitoring. So you have to do baseline LFTs and then at 3, 6, and 9 months. Second option is elinzanetant. It acts on both the NK1 and NK3 receptors. It's coming, and we hope to see it in about a year. I think Q3 of next year is what's expected. Next slide. These are some of the guidelines. Next slide, please. And at this point, I want to thank you for your attention. If you can't remember some things I said or you want more information, go to the mq6.ca website, and I think we're going to go to questions.
Great. Thanks so much, Sue, for bringing us up to date and telling us about some new options and clarifying for us many of the different options that are out there. So a few questions for you. I'm going to start with, there's a bunch of questions around perimenopause. So one of them, I'm going to read this one out, because I think this is a common experience. I'm currently getting inundated with questions about the premenopausal symptoms for women in their early mid-40s, apparently driven by social media trends pushing MHT for this group. What's your approach to this?
It's very frustrating. I want to validate that because everybody thinks that let's treat and it's going to prevent everything and make people feel better. You have to take an approach like you would with any other medical presentation. What are your symptoms? What's the diagnosis? In fact, there are over 30 validated symptoms of menopause. Women do complain of foggy headedness, ADD type symptoms, changes in sleep. Often the first complaint is their sleep is lighter than normal, it's more disrupted. The problem is the indications for hormone therapy are quite limited. As I said, vasomotor symptoms, GSM, and bone. People think that if we give them MHT, it will help their cognition. And the data doesn't really support that. Now, there's a little caveat there. If you're flashing, if you're not sleeping well, there's this horrible interplay between mood and cognition and sleep and the vasomotor symptoms. So if they have vasomotor symptoms, you treat that, or if you treat their sleep, cognition may improve. I think what they need is definitely got to validate their experience, because there's so much shushing off that doctors don't even realize there are symptoms in the perimenopause. I mean, that's sort of the bird's eye view.
Great, thanks, Sue. And around the question of treating those that are in perimenopause, can you comment on the decision as to whether to start MHT versus the oral contraceptive pill in a patient that's having regular cycles? So just wondering how you make that decision.
Based on partly on contraception and partly on risk of hormones, because remember that MHT is, a much lower dose of estrogen than even the low dose combined hormonal contraceptive. If someone's having a lot of period irregularity, I will often put them on a pill just to help balance out the periods. If they're afraid of estrogen or they don't need contraception, I'll go straight to MHT, but counsel about that, right?
Excellent. And just in terms of low dose, I'm assuming it's usually low dose contraceptions, oral contraceptives. Is it any low dose one that you can
Yeah,
use?
there's none, yeah, any of them.
Okay. And in terms of prescribing cyclically, there was a question around like what to do if the person doesn't have a bleed during that the 10 days or 12 days off the progesterone, or if they only have light bleeding. Is that of concern, or you just keep going through the cycle?
No, because if you remember, you're giving the progestogen for endometrial protection to make sure that you don't get endometrial hyperplasia. They may already have a thin endometrium and they may not get a withdrawal bleed. I think that if you've someone perimenopausal, you put them on a cyclic regimen, they're not getting withdrawal bleeds. I think you probably after a few months could just try them on a continuous.
Okay, great. Another question is that you had mentioned that you could use progesterone alone. And there was a question whether if you are doing that, would it be cyclically or continuously?
Continuously.
Okay. And also, do you know if MHT is covered by ODB? Are there options that are covered by ODB?
The only ones that I believe are covered, sadly, is the conjugated equine estrogen and medroxyprogesterone acetate.
All right. Then also just regarding hormone therapy, somebody would want you just to elaborate or repeat your comments regarding estrogen and dementia.
Okay, so estrogen does not prevent dementia. If you use conjugated equine estrogen in particular, because we have that data from the WHI, women who are initiated after 65 saw an increased risk in dementia. There are some subtle differences. There's a lovely white paper by Pauline Mackey about cognition. I think it's in my references or on that slide actually. There's a slight difference of other estrogens and other products, but basically it is neutral or causes increased dementia after 65 in particular. However, it was a little bit of data for people who are ApoE4 allele carriers, who are at risk for Alzheimer's dementia. There's some very new data that's come out that is still exploratory that suggests that that subset of patients may actually benefit from hormone therapy and it may protect them. Has to do with the amount of amyloid that gets accumulated and stuff. And of course, remember that our POI and our early menopause patients are at higher risk for dementia. And we do have some evidence that for that group, there may be some benefit and protection.
Okay, great. Thanks for clarifying that. Another question just around risks and side effects is the cardiovascular risk the same for all forms of estrogen?
No, and nor for progestogen. Just I'm going to add that. So Micronized progestogen is actually a bit better from cardiovascular. It's less thrombogenic. It has a more beneficial effect on diabetes and insulin resistance and on lipids. Now, when it comes to estrogens, generally we know that if you take an oral estrogen, it goes through the liver, you stimulate the liver and you stimulate the clotting cascade. So transdermal estrogens avoid that. So as a result of that, they have less of a thrombogenic risk. And that's why as patients age, we want people on transdermals. But that's at normal doses. There is some evidence that if you're at high doses of transdermals, the story may not be quite the same. The bigger picture of that is that when you look at the studies about cardioprotection and vascular risk, when used in these younger, healthier people, there's a bit of a mess of data. So you think it was absolutely clear that the data is absolutely, yes, everyone should be on a transdermal, and the data actually isn't there. What we say is if you have comorbidities, which increase your vascular risk, not high risk is a contraindication, but comorbidities that would increase your risk, we definitely say use transdermals. But for everyone else who's at low risk, it really doesn't matter because remember, hormone therapy is maybe cardioprotective in those younger, healthier people to start with. And there are times when you may want to be using orals. Like, for example, the Varughese is an oral pill, right? You don't want to say to someone you need to be on a transdermal because they don't need it. Does that?
Yeah, that's helpful. Yeah, I think that clarifies it. There's some clarity, and also there's still some ongoing work in terms of the higher doses with the transdermals. Another question just around hormone therapy and endometrial lining thickness. So I'm just going to read the question. A 57-year-old patient was started on HRT 5 months ago and had some spotting since the start. I advised that if it persisted over 6 months, we'd do an ultrasound. She went at 5.5 months and the lining is 7 millimeters and a biopsy was suggested. Is there a normal lining thickness for HRT and can I wait for biopsy?
Yes. So the answer is 11 and 4. So with HRT, women can have an endometrial lining of 11 millimeters, no problem. If they're asymptomatic, we're fine. But this person's not asymptomatic, they're bleeding. So somebody who is bleeding, the data shows that if they're under 4 millimeters, their likelihood of having a cancer is actually quite low. But this was 7 millimeters, and that's why the biopsy was recommended.
Great, thanks for clarifying that. A couple of questions around the older woman. So first of all, when you're thinking about the initiation at less than 60 or less than 10 years, is it whichever comes first? And I'm just going to give the example they gave. So if somebody had their last period at 45, could they safely start hormone therapy at 55? Because it's been more than 10 years, but they're still less than 60. Like, how do you work that out if they've had sort of an earlier menopause?
So it's a funny thing, and this is, I'm going to say my opinion based on what I've read. I think that time out from menopause is a little bit, when they look at the studies, it's like 10 to 20 years post final menstrual period. So when you think about why this all happens is you're worrying about what their baseline cardiovascular risk is because hormones are thrombogenic. The guidelines don't say and, they say less than age or you're safest if you're in less than 60 and less than 10 years, but technically you could start either. So if I had someone who was 64, but they were only, they had I don't know, they were 8 years out, I still probably wouldn't treat them. If they were 62 and they had a really late menopause and 4 years out, I might say that, yeah, they're over 60, but they've actually had the benefit of estrogen going along for way longer than normal. So the technical answer is actually or, not and. Does that make sense?
Yep, that's helpful. Quick question around the over 60. Can you use Tibolone in that group? Or is it the same, or do you have the same sort of concerns for 60?
It's a form of MHT.
Okay.
Now, understand that being over 60 is not a contraindication but we generally try to avoid starting because of the risk profile. We know you're safest under 60 or within the 10 years. Sometimes people insist they want it, and you have to counsel them, and you have to look at all of the other risk factors. And if you have a really healthy 62-year-old, you may choose to start them. We try to avoid it, but it's not a contraindication. It's just less safe.
Right, okay, another question just around safety. What tools can you use to assess breast cancer risk before starting hormone therapy? Are there particular tools that you use?
Breast density, that's basically the thing that we look at.
Okay.
And obviously family history.
Right. Another question is just in terms of hormone testing, because we often get asked by patients to, can you check my hormone panel? Do you have a way of dealing with that or some thoughts around that?
I do. And just to go back to the other question, I mean, there are risk calculators for breast cancer. There's the Gale model, you can use those. But if the question is, what do we do in care? We just look at breast density and family history. Okay. So blood work is next to useless. That's what I say. We do not use hormone levels for diagnosis. If you have maybe somebody who was on the pill and now you want to take them off the pill because they're hit 50 and you're not sure are they menopausal or not, you can stop the pill and they may get hot flashes. Or you could switch them a progesterone only pill because they still might be needing contraception. Wait 6 weeks. Then you could do an FSH and an estradiol. Wait another 6 weeks, do it again. So 2 elevated FSHs 6 weeks apart are diagnostic. But during the perimenopause, hormone levels are fluctuating all over the place, and doing hormone levels, they change from hour to hour. They're not diagnostic, nor should you be trying to aim for a certain blood level. An exception to that is when you're treating earlier POI patients where they think they try to get your blood levels up to a normal estradiol level for somebody who is premenopausal. I think they aim for 200 to 400. But for everybody else, really, we don't do blood levels. They're really not helpful. The other thing would be, the exception would be, if you're trying to diagnose someone who's maybe flashed and stopped and flashed again, think about, there's a great CMAJ article by Dr. Jacobson and Lega about, and it's on the website under the FAQs, what's a differential diagnosis of someone who starts to flash again, and not all sweats at later life are menopausal sweats. Go ahead.
Great, thanks so much, Sue. We're gonna stop here and we'll come back to a few more questions because there are some, but I want to turn things over to Dr. Varughese before the end of the session.
Thanks so much. And thank you so much to Eleanor and Ali for the whole year of amazing COPs. Our members have said multiple times that this is one of the things they look forward to. And it's a lot to do with our amazing team, as well as the amazing moderation that Eleanor and Ali have done over the course of the year. I want to take an opportunity to speak about something that we've been doing as a campaign to highlight the essential roles of family physicians. And so as we go to the next slide, the OCFP asked Ontarians a simple question. Tell us how your family doctor has gone above and beyond for you. And so the response was actually quite overwhelming and very heartfelt. We heard from 750 patients across Ontario telling us how their doctors cared for them. And it wasn't just a simple email back. Sometimes they collaged all the people that they had worked with their family doctor, and they shared their stories and how you support them, how their loved ones were able to work through it all, whether it was pregnancy, the births themselves, mental health challenges, caring for aging parents, screening, diagnosis, end-of-life care, really acting as the quarterback for the care of patients, especially when they faced any critical illness. So the OCFP is sending certificates of recognition to family docs that were nominated. And some patients were asked to share their experience in more depth. So as we go to the next slide, you'll see that we've created a video of what they said. Please take a few minutes to listen to this. Can we run the video?
I faced several health challenges related to adapting to a new climate, dietary changes and the stress of relocating. She did not only address my immediate health concerns, but also took a broader view of how my transition to a new country might be reflecting my well-being.
For my family, it was important because my parents don't speak English very well, and Dr. Ben speaks Cantonese, which is perfect for my parents. They're able to communicate with her.
Dr. Weatherston delivered me almost 39 years ago, and she has provided care for me, my own parents, and my now 2 children.
Dr. Fuss has given up so much time with her own family to help other people's families, and that includes evening and weekend clinics. She keeps track of all of my blood work and reports from multiple specialists, and she's the keeper of all of the important health information.
I am grateful for Dr. Arif, as she was able to get me the help that I needed when I ended up in emergency late last year.
So thanks, Jan, for that and for always being there and the way you take time and care to look after me and my mate's mother, who he sort of adopted as well. Well done, sir.
Ontario needs more Dr. Weatherstons.
There's no one else that I would trust more with the health of my children and my family than Dr. Anderson Kay.
Thank you, Dr. Newton, for all that you do for me and my family.
As a person with multiple chronic health conditions, she has been my healthcare rock.
And we know that nobody on this call would really need to hear that you're doing amazing work, but sometimes you do. And Eleanor's reflection is so important that in all the chaos of day-to-day work, sometimes we forget how much of an impact. For many people, coming to see the doctor is a life event. And so when it feels like just work, remember that there's a lot of lives that we touch. In order to amplify the messages that patients are sharing with us, we're sharing these stories with the media, and some patients are speaking directly to media to talk about how their family doctors mean so much to them. And so if you do see a social media post from the OCFP about the Life with a Doctor campaign, we would like you to consider reposting it and liking it yourself. Next slide. Patient recognitions are part of the new campaign called Life with a Doctor to highlight the essential roles of family physicians. And through this campaign, OCFP is putting forward solutions to address the challenges Ontario faces with regards to recruiting and retaining new physicians. Thank you very much. And just as I go to the last slide, I know that there was a lot of next slide. As we heard a lot of questions about pneumonia and how best to address it. Remember to look at your president's message. Recently in our last president's message, there was the mycoplasma tool that Janine had mentioned. So feel free to jump into those. We know that 70% of our members do look into our president's message, and we ask that the other 30% get the benefit too. Eleanor, back to you.
Great, thanks so much. Next slide, please. This is just a reminder of another session, and the fact that our sessions are in the available online if you've missed anything. Next slide, please. And these are the dates that are coming up in the future, more details to follow. And I believe that's the last of the slides. Any questions, always you can contact us. And I just want to say to everybody, I hope people have the opportunity for a bit of time over the winter break to get some rest and relaxation. And thank you for sharing that video with us, Dr. Varughese. It's lovely to see all the hard work and the dedication that so many bring to their work. It's just after 9. I didn't quite get to 9 o'clock, but 9:03. So those of you that need to sign off and start seeing your patients, you can always catch up with these last few questions by watching the recording after the fact. But we will just turn back for a few more questions for Sue and Janine, if they don't mind coming back on screen.
Busy typing, trying to get some of the answers in there.
Yeah, thank you. So I'll just start with a couple more for you, Sue, because I see them at the top of my list here. So again, around an older patient, can you use, sorry, can you use Prometrium after age 60 for insomnia and hot flashes?
That's interesting. So yes. I mean, Prometrium is better, as I said, in terms of vascular risk. Usually we're treating younger people, but again, I just want to, something was in the questions here. We're talking about age of initiation. So you wouldn't, we try not to start people after the age of 60 on hormone therapy, but it's not a contraindication. But if you're already on hormone therapy, you can extend through the 60s. We have some patients that want to go right through their 70s. And, 10% of women will have these bad flashes that start early and will continue on for years and years and years. So it's really important to remember it's the age of initiation when we're talking about those ages. And then you just do an annual review and look at their risk profile as they age, but they can continue.
Okay, that's good to know. I think just around the question of duration, is there any limit on the duration of the use of vaginal estrogen?
No, and in fact, I'm glad you got asked that question. Unlike hot flashes, which for 90% of people are time limited, if you have GSM, that is a gift that keeps on giving. And once things dry out, they're just going to keep getting worse and worse and worse. So you want to intervene earlier, not later, because you'll only get partial review, better tissue, I can't find the word, reversal, thank you. Only partial reversal. And vaginal estrogen is a lifelong treatment. And remember, it's a good thing because we have these older women getting a lot of recurrent UTIs. We have problems in the nursing homes. And a lot of that is because of their GSM.
Okay, that's good to know that it's safe and can be used and should be used potentially if you're starting it for longer duration. So last question, I'll do two last questions for you and then I'm going to turn things over to Janine. So this is a question of a patient in her early 50s with a lot of menopausal symptoms, but her mom had breast cancer and she herself has positive genetic testing for being a carrier. Would hormone therapy be safe?
The answer is probably yes, but I think that that's a discussion that she and her family doctor could have either with a geneticist or maybe an oncologist. I think for example, Dr. Jacobson in Toronto, she deals with a lot of breast cancer patients. And if I knew Michelle, if she said that person was really symptomatic, she would probably give them Duaviv. But it's probably a little bit above my pay grade as a family physician, so I would get someone involved. But I wouldn't automatically say absolutely not. I think it's worth a conversation.
Okay, great. That's really helpful. And then last question, I think you sort of have alluded to the answer to this question, but it's what is the best treatment for the 70+ population who've been told they shouldn't be on hormone therapy?
Ideally get them off because, in the WHI, there was deciles, right? So people, in the 50s were doing great, 60s did fine, 70s were initiated, at least at 70s, did poorly. Now, what we don't know is if a 70-year-old's been on for 20 years, do they actually have vessels of a 70-year-old? Or do they actually have vessels more like a 50-year-old? Because estrogen protects those vessels, right? And, as personalized medicine comes along, I think we're going to find ways to measure that. Having said that, what you try and do is get to the lowest possible dose, 25 microgram patch, half a 25 microgram patch, and definitely use a transdermal. And as you go down with estrogen, you need less progestogen. So if you're in a 50 microgram patch, for example, 100 milligrams a day of progesterone, but if you're on a 37.5 patch, maybe you're only using it 5 days a week. If you're on a 25 patch, maybe you're using it every other day. Maybe if you're, a half a patch, you're using progesterone once or twice a week. Remember, the progesterone is mostly for endometrial protection.
Okay, great. Thanks so much, Sue, for answering many questions. I'm going to turn things over to Janine. I think she's typing the answer to a question, but I'm going to ask her to maybe say it live. So the question is, what if someone doesn't want a cephalosporin and panallergic due to cross-reactivity? What next dose and duration would you recommend for community-acquired pneumonia? Because many of us are giving Z-Paks.
So great question, and I could talk about allergies for a whole hour. So really, your cephalosporins like cefuroxime, so second or third generations, are honestly absolutely fine to give to penicillin or allergic patients. So, and we routinely do that in hospital. so you can still give cefuroxime. The cross-reactivity is not as high as 2%. So all of the traditional, avoiding all cephalosporins, even with pen allergy, we really don't have to do that. So in hospital, again, routinely, even if they have anaphylaxis, we give them cefuroxime as an option. So cefuroxime 500 milligrams PO BID. So that would still far safer, weighing the risks and benefits of alternatives and resistance and all those things. That would still be your kind of second line after amoxicillin if you can't give that. I would put in a plug for trying to delabel your patients if they have amoxicillin allergies. If it's one where it was a long time ago, most of them are probably not allergic anymore, because about 90% of people that have a penicillin allergy actually aren't allergic. If you really can't use a cephalosporin, so they all have different side chains, so you still may be able to use them, but if you really can't, or the patient absolutely refuses, your next option is probably moxifloxacin or levofloxacin. I'm loath to say that because it's a big gun, lots of side effects, resistance, and risk of C. diff. But that would be 400 milligrams PO daily for moxifloxacin. 400 PO daily for 5 days. Yeah, that would probably be your next best option. And then if they have, if it's mild and you just want to, like, this is not good, but you really just want to give them something, and then you could still use azithro if you think it possibly could be mycoplasma. But the azithro or the Z-Pak just really shouldn't be first line if you really think they have like a pneumococcal pneumonia, because the resistance is quite high.
All right, great. Thanks for clarifying that. And very helpful to know that we can safely use second and third generation cephalosporins in patients with pen allergies. Another question just around medication is what to use to treat kids who end up with mycoplasma resistant to Zithromax. Because I guess guidelines say doxycycline if they're over 8 years old. What about younger people?
Yeah, good question. So in most cases, and I'm just trying to pull up the sick kids recommendation here so I make sure I say the same thing as them. But in most cases, even if it's resistant, it actually shows that people will still respond to a macrolide, and you're not going to have that information up front. So, again, you're still going to use that, see how the child is doing. If they're younger, you're probably going to avoid that. Then your next line, if they were still sick, and by that point, they may even be hospitalized, then your next option is a fluoroquinolone. So again, your levofloxacin or your probably levofloxacin in kids. Yeah, so that's kind of where you're at. But even with, I'm trying to find the reference here because I just read this yesterday, but even in people with resistance, the response rate was still quite high, that people still improved. So it's, you kind of have it in your mind, but it's not as scary as it sounds. Probably because they would probably improve anyways.
Okay, well, that's good. That's good to know. And I'm just going to finish with a couple of questions that I might have got answered because I no longer see them in my list, but I think they were good ones just around the swabs. So a couple of questions, whether should we be doing nasopharyngeal versus throat swabs for mycoplasma?
So either is fine and an acceptable method to do them. Generally, there's a bit better data, and sick kids is generally recommending throat swabs for that, because it seems to be a bit higher at picking it up. Although we seem to be having no trouble finding these infections. So either nasopharyngeal or throat, but a slight preference for throat. Obviously, I think part of it too is just technique. It's easier to do a throat swab, especially on a child. To get a good nasopharyngeal swab on a child, I'm sure you guys, it's not easy. I tried to do them on my kids at the beginning of the pandemic, and I was like, this is just not nice at all. So I would say throat swab you're probably going to get a better sample.
And then just a question, if we are doing a throat swab in the office, is it a special swab, or is it the charcoal swab that we use for strep, or is it one of the viral swabs?
So it's the collection kit is, I don't know if I can I put this in the chat, but it's, I'll put it in the chat again, like the public health has all of the exact ones, and there's like a specific mycoplasma pneumonia PCR kit that you can get. It doesn't show what it looks like. So I would want to double check that so I don't tell you guys the wrong one to use, but I added it in the Q&A a few times. So I can put it in the chat as well.
Okay, great, thanks. And we'll make sure that we include that in our resources anyway, when they go out with our slides and everything. And then I think you had answered this question, but I think it might be helpful for people to hear what, if you don't treat someone for Mycoplasma pneumonia because they're improving, what's the risk to those around them?
Yeah, so good question. We don't really know how long people remain, contagious with mycoplasma. The thought is that, and similarly to most infections, is that you're most contagious at the beginning of illness. So really in the first 10 days of illness, and even with mycoplasma, probably in the 2 to 8 days before you actually develop symptoms. So you've kind of missed the boat, to be honest, in terms of if you're using antibiotics just to prevent spread to those around them, all of their close contacts, and especially household contacts, which are always the highest risk, are already going to have had the most and significant exposure in that early stage. And so there would be no clear benefit to, it wouldn't be an indication to start them on treatment to reduce the risk of transmission to their contacts if they're already clinically improved, and then you get a diagnosis of mycoplasma later. And I think it's probably worth saying again too, if you guys are doing more mycoplasma swabs, it's really important to look at the patient in front of you to interpret them, because those swabs, we don't really know how long that PCR can stay positive, but we know people can shed the bacteria for, weeks, maybe even up to a couple of months after they've had the infection. So if they actually had mycoplasma in August, September, October, when there was more of a peak, and then you test them in December or January, if they're already better and their symptoms are more likely a viral illness, they probably have flu, and it's maybe hanging around from the mycoplasma. So I know that makes things even more muddy, but that's why when you're really think about, okay, should I do this test? Is it going to change management? And then if you get it back and it is positive, but the patient looks great and they've improved, don't feel compelled that you have to treat that positive result, right? You always, with anything we do, you gotta take the patient look in front of you as the most important thing.
Great. Well, thanks very much, Janine and Sue, for fantastic presentations and for answering many questions. I think we're all going to go into our day with a lot more knowledge, and just thank you very much. And that will close our session. Hope everybody has a wonderful weekend.